Hi, everyone. Welcome to Beyond the Diagnosis, Surgical Options for Parkinson's. I'm Sarah Osborne, and I'm a program manager for the Parkinson's Foundation. Next slide, please. Today's program is brought to you by Medtronic. Thank you, Medtronic, so much for your support. Next slide, please. During this time of social distancing, we hope you're able to stay safe and healthy at home. To help you stay connected, we're providing weekly educational and wellness programs in a virtual format through our PD Health at Home series. You can visit parkinson.org/PD Health to learn more and to register for these individual events. Today's session will also be recorded and archived on the Parkinson's Foundation website at parkinson.org/PD Health. So first, we'd love to know a little bit more about our audience today. So you'll see a polling question appear on the screen, and we'll pause for a moment so everyone can respond. Great, a few more seconds. Great, so it looks like we have a lot of people with Parkinson's on today and some healthcare professionals. Thanks everyone for joining us. So the next polling question, have you or your loved one had any of these surgical therapies? A few more seconds to respond. Great. So a few with DBS and some with the ablation surgery, and then a lot of people who are here to learn more. Thank you so much for sharing. Next slide, please. So the mission of the Parkinson's Foundation is to make lives better for people living with Parkinson's disease by improving care and advancing research today until there's a tomorrow without the disease. In everything we do, we build on the energy, experience, and passion of the global Parkinson's community. Next slide, please. We provide free resources, including our website, parkinson.org, our educational book series, webinars, podcasts, and our hospital safety kit, which is called Aware Care, and our toll-free helpline, 1-800-4PD-INFO, which is staffed by Parkinson specialists. Next slide, please. Additionally, we recently introduced our Newly Diagnosed initiative, which provides a great resource and starting point for those who are just starting out on their journey with Parkinson's. Next slide. We invest more than $10 million annually to support the most talented minds in research to explore what causes Parkinson's, how to treat it, and ultimately how to cure it. We recently launched a very exciting initiative called PD Generation, or PD Gene, which provides free genetic testing and counseling to those with a Parkinson's diagnosis. To learn more and to get further information, you can visit parkinson.org/PD Generation. Next slide, please. We bring local communities together through Moving Day, a walk for Parkinson's, a national grassroots event that's raised nearly $27 million to support Parkinson's research and local wellness programs across the country. This year, all spring Moving Day walks are going virtual, so you can join us online at Moving Day on May 9th by visiting movingdaywalk.org. To learn more about our resources and our upcoming virtual events, visit our website at parkinson.org, or you can call our helpline at 1-800-4PD-INFO. So today's host is J.M. Kenny, who is a producer, director, writer, and a person with Parkinson's. J.M. serves on the board of the Neuroboxing organization and is an active member of the Parkinson's community in Southern California. Please join me in welcoming J.M. Kenny.
Because I just got a little note that I'm supposed to start my video. So can you see me, Sarah?
Not yet.
Hang on one second. Are we there? Technology? Hi, everybody. Sorry for the little technological blip. I'm in the entertainment industry. You think I'd know how to work a camera. Hope you are all safe and healthy at home and taking care of yourselves and your loved ones. I'm so glad to have you here with us today. A little bit about me. For the last 30 years-ish, I've been producing content to market films for almost all the studios in Los Angeles. And in 2012, I was diagnosed with what is considered young onset Parkinson's at 46 years old. And like you, been living day to day, trying to make each day as great as it can be. I do a lot of exercise. I box with a group called Neuroboxing, which is a boxing modality to same kind of training that real boxers go through, yet no sparring. And so, you know, we're really excited today. We have a really great program for you today. Dr. Doris Wong is here. And before we get started, one of the things I like to do is take a couple of, you know, cleansing breaths. So if you can get your posture back up in your chair and do this with me, probably more for me than you guys, but posture up, and we're going to breathe in. And when we breathe in, let's not try to breathe into the chest. Let's try to breathe into the lower abdomen and focus our breath there. So we're going to breathe in through the nose and out through the mouth. So it'll look simply like this. Breathe in, hold for a second, exhale through the mouth. So we'll do 2 of those and then we'll get started. Okay, guys, here we go. So everybody breathe in, hold, exhale through the mouth. And one more, breathe in, hold, exhale through the mouth. Okay, well, like I said, this is a great program. And as a reminder, your questions can be submitted by clicking on the Q&A icon in the black banner at the bottom of your viewing page at any time during the program. We'll do our best to answer as many of those questions as we can and during the Q&A segment. So as I said, our speaker today is Dr. Doris Wong, neurosurgeon at University of California, San Francisco, where she also earned her doctorate in neuroscience and her medical degree. Dr. Wong specializes in surgery for patients with movement disorders such as Parkinson's disease. Her research uses deep brain stimulation devices to better understand the dynamics of the brain networks as humans learn motor skills. So please join me in welcoming Dr. Wong.
Thank you so much, JM. Can everybody hear me okay? All right, well, it's an honor and a pleasure that you guys can join me here today to talk about something that's close and dear to my heart, which is talking about surgical options, other things we can do for patients with Parkinson's disease. Okay, so without further ado, I'll get started. So the main things I want to talk about today is, first of all, now a lot of patients have diagnosis of Parkinson's disease and medications working well or maybe not so well. So when is a good time to consider surgery? And second, what type of surgical options are there for patients with Parkinson's disease? And finally, am I a good candidate for any types of these surgeries? So I'm hoping to clarify all these points for you today. And if you have any questions, please feel free to submit to the Q&A box and I'll try my best to answer them. So as most of you are aware, Parkinson's disease is the second most common neurodegenerative disorder affecting more than 1 million Americans. And it's about 1% of adults over the age of 60. It is a progressive neurodegenerative disorder that manifests as many types of motor impairments. And the cardinal features are those of bradykinesia, meaning slowness or lack of movement, tremor, and rigidity or stiffness, as well as gait and balance issues. But what these motor symptoms listed here are only the tip of the iceberg, since these are the symptoms that are visible. PD actually encompasses a wider range of other non-motor symptoms. These include mood disorders, cognitive problems, GI urinary symptoms, sleep disorders, as well as autonomic dysregulation. So many of the motor and non-motor symptoms emerge through different stages of the disease progression. When someone's first diagnosed in stage 1 of the disease, person has very mild symptoms that generally do not interfere with daily activities. So some of these symptoms may include tremor, a little bit of slowness, stiffness, and mostly occur on one side of the body. However, as symptoms starts to get worse when you start progressing into mild moderate stage, stage 2, these symptoms as tremors, stiffness, and other symptoms start to affect both sides of the body. And you may also start noticing some walking problems and poor posture. Once we progress to stage 3, this is considered mid-stage, that's when the slowness movement are becoming more hallmarks of the problem, and also falls can be more common. The patient is still fully independent, but the symptoms are now significantly impairing activities of daily living. In stage 4, symptoms are severe and limiting. So while it is possible to stand and walk without assistance, the patient does need help with activities of daily living and is unable to live by him or herself. And stage 5 is the most advanced and debilitating stage of the disease. So at this point, a patient is no longer able to ambulate or mobilize independently, may require around-the-clock nursing care, and some of the non-motor symptoms, hallucinations, delusion, become more apparent. So another way to look at Parkinson's disease progression is in terms of response to medication. So levodopa, dopamine replacement. So during the initial diagnosis, the patient may not require medicine, or just one dose of medicine taking it at the beginning of the day can actually last through most of the day. And the symptoms are very well controlled on medication. However, as disease progresses, once you get into kind of moderate stage, medication basically does not last as long anymore. So after initially taking the medication, you get some hours of benefit, but then you have to keep redosing the medication in order to get benefit. And when you do get benefit, this on time may be also associated with involuntary movements, also known as dyskinesia. And of course, as disease progresses, this therapeutic window narrows even more over time. So basically, a patient is fluctuating between off state, a little bit of good on time, then very disconnected state. So this fluctuation can become very debilitating and also interferes with a lot of daily activities. So what we know is that these troublesome and unpredictable motor fluctuations in dyskinesia can begin as early as 2 years following initiation of medical therapy. And within about 4 to 6 years of initiating levodopa treatment, about 40% of Parkinson's patients can experience motor symptoms that impact their quality of life. So once you're getting to this motor fluctuating stage, kind of in the moderate stage, that's when we should start considering surgical options to better control the symptoms. So today I will talk about mainly 3 types of surgeries we can do for patients with Parkinson's disease. First is DBS, or deep brain stimulation. Second, I'll talk about another type of brain surgery where we lesion or ablate part of the brain to control those motor symptoms. And finally, I will talk about intestinal levodopa suspension therapy. So first, DBS, which is short for deep brain stimulation. It is essentially a pacemaker device for the brain. So it's a fully implanted device that consists of 1 or 2 electrodes implanted in very specific areas of the brain. And it's connected through an electrode all underneath the skin to a battery that's implanted over the chest called battery or pulse generator. So the battery provides energy to deliver electricity through the electrodes. In short, DBS uses an implanted electrode that delivers stimulation to structures of the brain involved with movement, as shown here. So the FDA-approved targets for PD include a specific nucleus in the thalamus called the VIM, which is good at controlling Parkinsonian tremors. The subthalamic nucleus, STN, or globus pallidus interna, GPI. So these targets can control tremor, slowness of movement, rigidity, and some of the other motor symptoms of Parkinson's disease. And the theory of how DBS works is that the stimulation can bring abnormal neural activity in the motor control circuits to a more normal state of function. So what does DBS therapy involve? So first, it involves a group of implanted components. So that's a hardware that needs to be placed in the right location, connected to the pulse generator that can deliver energy. And you have your choice, depending on what you need, of different types of pulse generator. And to interact with the device, the clinician and the patient have these devices can wirelessly transmit and communicate. So for instance, the clinician would be able to set different settings or programs to your DBS device. And the patient themselves actually have access to a remote control, which allow you to turn the device on or off, or turn up or down its volume, and switch different channels to different settings. So currently, there are 3 main types of devices from 3 different companies that are on the market. So Medtronic, Boston Scientific, and Abbott. They all have slight differences, but the general principle of how it works is the same. And for details about these different systems, I believe they're going to put up a link in the chat box from the Parkinson's Foundation publication that you can refer to. So in summary, DBS is a fully implanted device that's reversible as well as adjustable. However, it is a complex therapy. It involves a neurosurgeon to implant the device in the right location, as well as programming by a movement disorder neurologist to adjust the device so that you can get the maximal benefit. So now I will talk a little bit about what I do, which is how we implant the device. So the traditional way of implanting the DBS device is by awake stereotactic neurosurgery. What that entails is that before surgery, we get a good picture of your brain through usually MRI, and we plan exactly the trajectory, the path to get to the area and the target of choice. On the day of surgery, the patient is placed in a head frame, temporary head frame, that can give us then the coordinates or the map to reach the area that we want to. And since we cannot see as the electrode is passing through structures of the brain in real time, we actually listen to the neurons by passing this thin wire and listening to different cells' firing patterns that can give us an idea of where we are in the brain. And once we're happy with the location, then we place a lead and perform what's known as intraoperative testing. So we turn on the device temporarily to see if we can control some of the symptoms, such as tremor, and make some of the other symptoms, rigidity, bradykinesia, go away without causing a lot of side effects. So that's a traditional way of how we place the DBS electrodes. In the early 2000s, my colleagues at UCSF, Dr. Philip Starr and Dr. Paul Larson, invented a new way of implanting DBS and performing DBS surgery in the MRI. So we do the entire surgery with a patient under general anesthesia and a magnet. So basically, we do not need patient to be awake to perform these tests. So we temporarily place a skull mount aiming device on the patient's skull during surgery. And with these controllers, we can aim at exactly where we want to. And since the patient is in a magnet, we can basically perform serial images to visualize as the lead is penetrating through the brain to arrive at the correct target. And based on our experience, we have equally good clinical outcomes with either the sleep technique using the MRI or the traditional awake technique, really expanding our capability of applying this technology to different types of patients. So now that we talked about what DBS, or how we do the DBS surgery, so what can DBS help with? So it helps with tremor. Basically, it takes the best on medication state, keeps you there longer throughout the day, so extends the on period and reduces these fluctuations that I showed earlier. It can reduce dyskinesias, it can reduce stiffness, slowness, freezing, and shuffling. The only caveat is that with these symptoms, basically, if they can improve with Cinemet, with Levodopa, then then DBS is very likely to help with these symptoms. So this is an example of, one of the patients implanted at our center. So on the left is, the patient's motor state before DBS surgery. You can tell that she's very stiff, slow, there's tremor, she's having problem even taking the first few steps. And after DBS surgery, you can tell she's able to ambulate very briskly, moving a lot more faster, more naturally. So while DBS can help a lot of the motor symptoms, it's not a perfect therapy. It doesn't slow down the progression of disease. It cannot cure the disease and doesn't help with a lot of non-motor symptoms. So, swallowing difficulties, speech problems, the GI symptoms, memory problems, and cognitive problems, DBS at its current state does not help these symptoms. And the other big question is, it sounds pretty scary having these electrodes in your brain. So what are the complications for this therapy? So of course, every operation carries a risk of complication. The one that people worry a lot about is a risk of bleeding. So overall, with electrode penetration, it carries about 1% overall risk of bleeding. And about half of those actually result in a permanent or transient deficit. So those are symptomatic hemorrhages. Actually, the highest risk in terms of DBS complication is that of infection. So depending on the literature, it's about 2 to 5% risk of infection. And depends on the type of infection. If it just involves the skin, it can be treated with oral antibiotics. However, if the hardware, especially those in the brain, becomes infected, then the whole hardware needs to be removed. Patient needs to be treated with IV antibiotics, and then we can reconsider reimplantation after that. And then finally, one of the concerns is that what if I go through this whole operation and my symptoms don't get better? So the best outcome or predictor of success is having confidence in diagnosis. So if we know that you have stereotypical Parkinson's disease, usually now with good technology, the malpositioning of electrode risk is pretty low. So we can usually minimize those risks. So now we want to talk about who is a candidate for DBS therapy. So again, I want to stress that DBS should be considered when the patient, despite optimal medical therapy, develop motor fluctuations. So that means those with moderate severe PD. Again, we want to consider DBS for patients with idiopathic PD, meaning PD that's kind of bread and butter, doesn't have any worrisome features or atypical features, since a lot of neurodegenerative disorder can mimic Parkinson's disease. We want to look for those patients with a good levodopa response. So usually that means a greater than 30% improvement in the motor subscore of the UPDRS score. And we want to look for patients who don't have significant cognitive impairments, just because it is a pretty involved therapy requiring device maintenance, going to these follow-up appointments. And finally, like all surgeries, we, for those who have significant medical comorbidities, that means, diabetes, heart disease, the risk of surgery is greater. It's not an absolute no, but the less medical comorbidities, the less the complication profile. DBS could also be considered in milder cases. So for patients with significant tremor that requires large doses of levodopa to control the tremor, or if the tremors are altogether resistant to levodopa, then we can start considering DBS even before they have significant fluctuations. Also, for some of the younger patients often have off-med dystonia, so painful muscle contractions and cramping. So DBS can be considered early for those cases. And those with an active professional life in which levodopa medication and those symptoms can have significant implications. So we can consider for these special cases earlier in the disease course. So overall, the goal of DBS therapy is to maintain or improve motor function before significant disability ensues. So it should not be a last resort intervention, because we can restore many good years of quality of life before we get to the severe kind of end stage of PD. So now I will switch gears a little bit and talk about the other type of brain intervention we can do as neurosurgeons, which is called brain lesion or ablation therapy. So these are just fancy words for basically we're making a hole in the brain. So there are two types of lesions that we can place depending on the anatomy and the target. Again, one is kind of near the VIM region of the thalamus called thalamotomy. So again, that treats a Parkinsonian tremor component of the symptoms. And then the other type of lesion we can perform for PD is called pallidotomy. So where we lesion the GPI, the globus pallidus. And that can treat tremor, rigidity, as well as bradykinesia. So how do we make the lesion? Mostly pretty similar to DBS, actually. So the first method I would describe is called stereotactic radiofrequency ablation. So it's very similar to DBS. We plan the trajectory and the target based on the patient's preoperative MRI. And day of surgery, the patient is placed in the head frame. And we, instead of the DBS electrode, we insert the lesioning electrode, the probe. And then basically using radiofrequency to heat up the probe tip, we can then burn a hole right in where we want to. And the patient during this process is awake, is participating in continuous neurological exam to make sure that we're not causing any side effects and that we're seeing a benefit in some of the Parkinson's symptoms. So the advantages of this procedure is that it's immediate. We do have intraoperative testing to confirm the benefits. And the cons is, like any DBS surgery, we're passing a probe through the brain. So there's always a risk of hemorrhage. And also we require patient to participate. So it's awake surgery. So now with advances in technology, there are other ways we can make the lesion. So another way we can do it is using laser fibers. So in this technique, it's kind of like the sleep DBS component that we do in the MRI. The patient can be completely under general anesthesia. We again put a small hole in the skull, pass a very thin laser fiber into the target of choice. And basically, again, it heats up the tip of the probe, lesioning the tissue that we're targeting. And again, because the patient is in the MRI, we can do serial imaging to watch the size of the lesion. So the pros of this technique is that it has immediate effect, doesn't require patient participation. Always there's a risk of hemorrhage because we're putting a probe into the brain. And since the patient is asleep, we won't be able to do intraoperative testing. So again, this is purely image-based technique. And a lot of you probably have heard of a new way. This is called focus ultrasound. So again, using MR guidance, instead of putting a probe in the brain, it uses very high frequency ultrasound to basically pass high frequency sound waves through the skull and to the center of the brain. So this procedure was approved by the FDA in 2018, and currently it's only approved for targeting the thalamus. So this procedure can only be used to treat tremors. But in this procedure, the patient is actually awake. It has an immediate effect. And the best part is that there's no incision or burr hole. So it's an incisionless surgery. And the con is that, depending on many other factors, the lesion size could be variable. So who is a candidate to receive lesion surgery? Pretty much the same patient who are candidates for DBS surgery. So again, those with moderate severe PD without atypical features, good sentiment response. The only thing that can tolerate a little bit more is, if you do have some cognitive impairments, just because it's a once and done procedure, it requires less patient follow-up, and there's no device maintenance. So those with mild cognitive deficits might be able to be a candidate for lesion surgery, whereas they might not be for DBS. And also those with some medical comorbidities. Again, because there's essentially no risk of hardware-related infections. So the risk profile is a little bit less than those for DBS surgery. So what are the advantages and disadvantages of a lesion surgery? So the biggest advantage is that there's no implanted hardware. It's a single surgery, it's once and done, whereas with DBS, it requires follow-up programming, maybe battery changes, and a lot of follow-up appointments later. So there's no programming. The disadvantages is that mainly it's a unilateral procedure because we know from past experience, performing bilateral thalamotomies or bilateral paladotomies can cause speech problems and other unwanted side effects. And it's not adjustable. So as disease progresses, symptoms get worse, whereas DBS, you can, turn on different programming options or turn up the stimulation. You cannot increase the size of the lesion, usually, and it's irreversible. So finally, I want to talk about the third type of surgical intervention for PD. It's called intestinal levodopa suspension. So in this therapy, we're kind of switching gears from the brain now to the gut. This levodopa carbidopa intestinal gel, so LCIG, received FDA approval for use in the USA in 2015. The system consists of a portable pump that delivers levodopa carbidopa through a PEG tube. And a PEG tube is a permanently placed catheter that is passed into the stomach, through the stomach into the intestine. And the other end of this catheter comes out through the skin. So it's very similar to a port. And this port is connected to this external pump that infuses the medication at either a constant rate or in boluses when needed. So the advantage of this system is that it can bypass some of the issues dealing with gastric emptying. So therefore, it can deliver a more constant level or controlled level of dopamine through the patient's system. So who is the candidate for receiving LCIG therapy? Again, those with advanced or more severe PD can receive this therapy. Again, you should only receive it if you are having a good response to levodopa, but just having a lot of motor fluctuations. And while, patients with some cognitive problems and mood depression can get LCIG, it does still require good caretaker and social support in order to manage the port and the pump. So the advantages of the LCIG therapy is that, we bypass the brain. We're just delivering medication to the gut. It is adjustable, it's reversible. And again, as I mentioned, those with cognitive impairment and depression, which may be contraindications for DBS therapy or lesion therapy, these are not contraindicated in LCIG therapy. However, the PEG tube itself can lead to many different complications, including dislocation, disconnection, occlusion. There's always a risk of infection. There's a risk of device malfunction. And also there's always a risk of medication-related side effects, including sleep disturbances, psychosis, hallucination, as well as mood problems. So in short, there are many options to manage PD symptoms when medication alone becomes inadequate. So we should think about surgical options for our patients once motor fluctuation develops. And there's no single best option that's suited for everybody. So every patient should be considered individually, and the therapy should be tailored to the needs of the individual. So with that, I would like to thank the UCSF Department of Neurosurgery and our wonderful, amazing movement disorder and neuromodulation group, and who has been very supportive, and we work seamlessly together to create a multidisciplinary treatment center for patients with movement disorders. And here's our link in the bottom of the slide. So with that, thank you so much for listening, and we'll move on to the Q&A portion.
Awesome.
All right.
Can you hear me, Dr. Wong?
I can.
Thank you so much for that presentation. Very informative. Wonderful, wonderful material.
Thank you.
So I'm going to start with some questions from our participants today. Our first question is, does DBS wear off or become ineffective over time? And how long does it usually last?
That's an excellent question. So from what we know, DBS therapy lasts through the lifetime. So basically we know that from, studies that we've done following patients who had DBS therapy for, decades. And also when their big DBS battery wears off, when we change their battery, we can still see a lot of the benefit, the motor benefits that I talked about earlier in terms of reducing tremor, reducing rigidity, slowness of movement. But of course, as disease progresses over time, the benefit may seem less because the patient becomes more preoccupied or other non-motor symptoms becomes more apparent. But the therapy does last.
So like young onset patients should not feel that this doesn't apply to them until they reach a certain age.
Correct. I mean,
Wonderful.
As new symptoms emerge, sometimes, you need additional programming, and rare instances, you may need additional set of electrodes to control the symptoms, but it still should help.
All right, here's our second question. What is the evaluation process like for DBS or other surgical options? Will the doctors take any other conditions I have into consideration?
That's a very good question. So in terms of getting evaluated for DBS, as soon as, you have a diagnosis of PD, for patients at our center, basically we approach it from a multidisciplinary perspective. The workup involves initial consultation with a movement disorder neurologist as well as a neurosurgeon. So we just want to go through the history, confirm that, again, you do seem to have the stereotypical idiopathic Parkinson's disease. Then if the patient is determined to be a good candidate, then we get an MRI of the brain to make sure, rule out any structural causes of their movement disorders. We get an on-off testing where you come into the clinic, not taking any of your medication, Parkinson's medication, and a neurologist does a full UPDRS, so Parkinson's rating scale, to see how bad your symptoms are. And then we have you take the medication in clinic and then redo the exam to see how much of your symptoms improve. Again, that would predict a good response to the DBS. And the third component is getting a neuropsych testing. So with a special neuropsychologist. Again, this is to assess, your cognitive memory, processing, and and also mood, just to better inform us which target may be better for you. And just what are some of the mood and cognitive complications that may happen. So those are the three components for workup.
Wonderful. This next question comes to us and it's sort of like, measuring the benefit of surgery over the medication. The question really is, if candidates for DBS have a good Cinemet response, then why have the surgery like DBS?
Very good question. So if you, refer back to the slide in terms of disease progression and the chart of medication response, if you are having good Cinemet response and, you don't mind, you're only taking medication maybe once or twice a day, then I agree, you should not be getting surgery at that stage. However, if medication is not lasting as long and you're starting to see these fluctuations, where you have unpredictable response to medication, you don't know when it's going to kick in, or it's wearing off more rapidly, and you have to take medication 3, 4, 5, or 6 times a day, then it's a good time to start considering DBS, because we know from our experience is that once you reach that fluctuating point, then the medication is going to last shorter and shorter period. You can, do some more adjustments and try different formulations, but to get the maximal benefit, you probably have to seek something more than just medication.
And I believe that this was touched upon in the presentation, but dyskinesia, which, dyskinesia I think is sort of a side effect of Cinemet in a lot of ways.
Exactly.
Does DBS mitigate that, or is that just,
it does.
as it is?
Yeah, so, as you mentioned, when you take too much Cinemet or Levodopa, you can develop involuntary too much movement known as dyskinesia. So what DBS can do is, one, by reducing the amount of medication you take, so it can reduce that. And also, again, it just kind of evens out the motor fluctuation in reducing dyskinesia.
Awesome. So our fourth question is, what procedures are happening during the COVID-19 outbreak?
Mm-hmm.
What is considered an essential procedure versus non-essential related to Parkinson's disease?
Yeah, I know. In these crazy times, it's unfortunately we have to put on hold a lot of the DBS procedures. So I think it's very regional specific and dependent. At UCSF, we are actually currently doing some DBS procedures for those patients, again, whose quality of life is severely impacted. In some other areas, such as New York, my colleagues are not doing any DBS surgeries besides, battery changes, which is considered urgent and essential. So it's very regional specific. And, from our perspective as neurosurgeons, all surgeries are essential. We're taking care of our patients, trying to restore their quality of life. So it is important, as opposed to maybe plastic surgery. So, we have to work with our medical center, our public health officials to do it safely and thoughtfully. And that's what we're currently doing at UCSF.
Are there any physical restrictions for those who have undergone DBS? Are people still free to exercise and do the things they would normally do?
Absolutely. So our goal is to restore you to, the best motor state that you have, and not have this therapy interfere with your life. So we encourage patients to exercise, to travel. We have patients who went scuba diving after DBS surgery. So yeah, it shouldn't be interfering with your life. We're trying to restore your quality of life.
Another question comes to us. Do any surgical interventions for some of the non-motor symptoms, including anxiety, depression, and apathy?
Are there any, just specifically for those symptoms, right?
Well, are there any surgical interventions for some of the non-motor symptoms? Some of the things that we all as patients feel,
right,
but not necessarily know, is it more medication or is there something that the surgery can do?
In its current state, we don't have a good surgical option to treat these non-motor symptoms such as depression, anxiety, cognitive impairments. I will say, my colleague Phil Starr at UCSF, we are investigating other type of therapy, surgical therapy to help with those symptoms. So those are still, undergoing a lot of investigation. We're trying to understand the brain circuits that are involved with these mood dysregulations and cognitive dysregulations. We're looking for ways to use DBS or other neuromodulation therapies to help those non-motor components of Parkinson's. We're working on it.
Excellent. How long do patients typically have an intestinal pump? How invasive is the placement of an intestinal pump, and does the equipment interfere with daily living activities, or are they fairly simple to wear/maintain?
So in terms of the pump, the patient has it implanted permanently. So my understanding is unless there are, complications associated, it will be there permanently, infusing medication. And what's the second part of that question in terms of?
This is one that I find very interesting is how does it affect your daily living activities? For example, it's an external pump. Is there an issue with showering? Is there an issue with, sleeping with it? It's like, what are some of the,
Sure.
Is it simple to wear and maintain is ultimately the question.
Yeah, it's pretty small, and you can carry it around. It's almost like a fanny pack. And, you know, again, the external pump can be disconnected from the catheter, the port, pretty easily. So, you know, once you're showering, you know, you can remove the pump component of the device.
Okay. Another question is, what are some of the technical innovations with DBS, and also where do you see the future of DBS, or what's around the corner possibly?
Yeah, that's a great question. So since DBS therapy has been around for, you know, 20 plus years now, there has been some really exciting developments within the world of DBS. And actually, I'm going to share some of my slides again. So one avenue is exploring directional leads. So basically giving clinicians more fine control over where the current is going. So traditional leads are cylindrical. They're arranged kind of in a ring configuration like this if you cut across a lead. So basically when you deliver electrical stimulation, it spreads circumferentially 360 degrees around. Now, a couple of the companies have come up with these directional leads. So where the lead themselves, the metal part of the contact, they are fractionated. So you can control where the electrical current is going. So the whole idea is, you know, when we place a lead, if we stimulate, if it's placed perfectly well, you know, we can reduce a lot of these motor symptoms we talked about, tremor, rigidity, akinesia. However, nearby structures, there are a lot of nearby structure in the brain that you don't want to stimulate. So for instance, if you stimulate a little bit to the right here, you can cause muscle contractions, eye deviations. So the whole idea is that with current steering, you can increase the therapeutic window. So basically really control and shape where the stimulation is going. So you can maximize motor benefits and symptom relief while minimizing side effects. And then, so, you know, that's one side of the DBS technology. We have a lot of this technology today right now. And the next really exciting direction is called adaptive DBS. So closed loop control DBS. So current DBS basically works by just, you know, having constant high frequency stimulation to the brain structures. So doesn't take into consideration different medication states and how the symptoms may fluctuate over time. So the next generation of DBS is aimed at, you know, developing these smart devices where we listen to the brain signals, so we can record the brain signals in real time. We can then implement algorithms within the battery to analyze these signals and then give a feedback and change and adapt the stimulation parameters. So it's like, you know, a pacemaker where it detects abnormal heart rhythm and only shock the heart when it needs to. So this is super exciting technology, and I'd like to share some of the results by my colleague, Phil Starr here at UCSF, where this is only an investigational device that has bidirectional sensing and stimulation capabilities. And this is made by Medtronic called RC+S. So this is one of the patients we implanted, and he has severe motor fluctuations, and he gets disconnected very easily with, you know, a single dose of levodopa. And what graphs you're going to see here is here's our detection of the biomarker, his brain signal that's associated with dyskinesia, and this is the current that's going into the brain. So basically, when you are getting dyskinetic, the idea is that we should reduce the amount of stimulation. So here he is doing some activities, and right around here, he's starting to get dyskinesia. You see that head jerk movement? And now the device, our research team has programmed it so that it reduces the current of stimulation. And here he is about to get very dyskinetic again. And this is detecting his brain signal in real time. And now his pulse generator is adapting to it and reducing stimulation. So now ramping closer back down to 0. So there's a lot of tremendous research in this direction, you know, led partially by our group here at UCSF, by Phil Starr, and others around the world. So I think this is a very exciting direction to develop these smart adaptive DBS. All right.
Wonderful. Thank you for that. So are these surgical procedures typically covered by a person's insurance? You know, does it vary based on your age, your plan, and the disease severity?
So typically these procedures are approved by insurance. It's an FDA approved procedure, Medicare, as well as private insurers approve it. So there shouldn't be any issues. I mean, if you have, some atypical features, but if it's clinically indicated, there usually isn't any issues with insurance coverage.
Also, can the patients and in many cases the care partners make adjustments to their own devices, or who is programming the system?
Right. So these systems are programmed by neurologists or movement disorder specialists who has a lot of experience in programming them. That being said, we may give some flexibility to the patient themselves in terms of controlling the amplitude of stimulation. So we may give patient a range, to go between 1 milliamp to 3 milliamp, which, if they feel that they need more stimulation because they're not getting full benefit from their usual dose of medication, they can turn it up or turn it down accordingly. So it's within the settings and the freedom, I guess, your neurologist gives you in terms of actual programming.
How often is DBS reversed? When would a reversal be necessary?
You mean taken out completely? So it's taken out if you have hardware-related complications, so infection. It can be taken out if there's a breakage in the system. Usually those are more for replacement. We've hardly ever had anybody who, after getting DBS therapy, wanted to be taken out entirely. I suppose if you're not getting any benefit at all from DBS, either from misplaced leads or misdiagnosis, then it's possible to remove them, but that's extremely rare.
Okay. For some of these procedures, when the patient's awake, how does the surgery team manage patient stress and ensure comfortability during the procedures? That's a great question.
Absolutely. So that's part of the reason why we developed the sleep technique, because a lot of patients don't want to or can't handle awake surgery. But if they do take awake surgery, there is a baseline level of sedation sedatives that the anesthesiologist gave. And actually through most of the procedure, in terms of the more stimulating parts, pinning, making incision, drilling the skull, the patient is actually completely asleep pretty much during that time. And then we give, reversible, quick acting anesthetics, and then we can stop that. We really need patient to be awake during the testing part and the microelectrode recording where we're listening to your neurons. So it's, a pretty short window. Again, a lot of it is patient expectations. So we tell them exactly what's going to happen. And throughout the procedure, we have wonderful anesthesia staff, nursing staff, also the surgeon themselves. We actually come around the drape and talk to the patients to help them through these, really it's a scary thing to be undergoing awake brain surgery. So we try really hard to make sure that the patient is comfortable.
Is there a point where, some of the anxiety is post the surgery, where the anxiety of the machine in their body and operating and not knowing what they're going to feel, or even though they've been told to what they can expect, it's still very new to that particular patient. How do you approach that, the post-surgery?
Yeah, absolutely. Mood dysregulation, it's rampant. It's it's hard to think of many patients I have who don't have some sort of anxiety or mood dysregulation with their Parkinson's disease by the time they want DBS surgery. So a lot of it's, managing expectations up front. Again, at our center, we're very lucky in that within our movement disorder center, we have a geriatric psychiatrist who works super closely with our group. So if there is concern on their neuropsych testing or by, their initial consultation, we have significant concern about this particular patient's mood dysregulation. we actually would have that patient see a psychiatrist to, optimize their medication, recommend psychotherapy or whatever can help both before and after surgery. So it's really important to have this multidisciplinary approach because DBS, frankly, in some cases can cause psychosis and exacerbate pre-existing mood disorders.
Cool. So I think this is our last question for the time that we have with you. There seems to be a stigma with these procedures as being the last resort. And I know you mentioned that in your presentation, but how has that changed over time?
Right. And it shouldn't be a last resort. What I tell patients is that, if your quality of life is severely limited by your symptoms, which is no longer adequately controlled by medication, what we can do is kind of, I don't want to say turn back time, but restore those quality of life, just extending that few hours of good on time you have during the day and extending that longer. Yes, it is invasive therapy, but as I mentioned in our complication profile, the overall risk is still quite low. Over 95% the chance you're going to have a phenomenal outcome. So don't think about it as last resort. Start thinking about it earlier, and the things that you used to be able to enjoy doing, but is no longer able to do because of these motor fluctuations and motor complications.
Well, thank you so much for sitting with us in that incredible presentation. We're grateful to have you here. I want to let the folks that are watching know that if your question wasn't answered today, please call 1-800-4PD-INFO, that's INFO, or email helpline@parkinsons.org, and we will answer you directly. So in closing, we'd like to thank our sponsor, Medtronic, who made today's program very possible. Our next slide. We hope to see you tomorrow at 9 a.m. Pacific Time, 12 p.m. Eastern Time on Facebook Live for Ask the Expert, Managing Your DBS Device During COVID-19, with Dr. Michael Oken, who is the Medical Director for the Parkinson's Foundation. For a complete lineup of all of our PD Health at Home virtual programs and for a recording of today's session, visit the Parkinson's Foundation website at parkinson.org/pdhealth. You'll receive a short survey by email after today's program. Please take a minute to complete the survey, as we'd love to know what you thought and what else you'd like to learn about. Thank you again for joining us, and please stay healthy and have a great day.
Thank you.